Good evening, everyone. This is Dan Green. Sorry to be late. I was actually on a different webinar. There were two links that came up in the go-to webinar, and one said Sunday, August 15th. The other one said the 17th. And I clicked on the wrong one and was talking to myself for about the past 7 or 8 minutes, which I knew no one was on, but I'm very relieved to see you guys are actually on, because it's hard to do a webinar for an hour by yourself. So apologize for being late, but glad you guys are all in attendance. So if you give me just a second, we'll get going here. And again, I apologize for the foul up on my part. Let's see. Tonight is Sunday, August 15th, 2021. Given that it is a Sunday, we will be doing cases from your case list. So I would ask, if you want to be in the hot seat, please raise your hand. If not, I will volunteer you guys. And yeah, we will get going then. Ashley, good, thanks. Let's see if we can get you unmuted, Ashley. Okay, up. Oh,
hi.
Hey, sorry about the mix up tonight. I'm better now.
I was like, am I in the right room? Am I not in the right room? So, but we're good. We're here.
It was going to be a long hour, me quizzing myself. Okay, so fortunately we don't have to do that. Ashley, refresh my memory. Are you a generalist or specialist?
I'm a generalist.
Okay, and you sent your list in, did you not?
I did, and I believe that you should have them now. Last week they were.
We do. Look at that. So something's working tonight. That's good.
All right.
Okay, in a second you'll see your case list.
Oh, yeah.
So, patient number 1 had abnormal uterine bleeding. Can you tell me what the POM-Cohen stands for?
We did this already, didn't we?
Oh, we're going to do it again for a second.
Let's do it again.
That's not the whole question, but go ahead.
Okay, perfect. Okay, so POM-Cohen for abnormal uterine bleeding, the POM represents the structural causes of abnormal uterine bleeding. The Cohen represents the non-structural causes of abnormal uterine bleeding.
Okay, can you give me an example of, or can you tell me or spell out the acronym and tell me what each letter stands for in the Cohen?
Yeah, so C stands for coagulopathy, O stands for ovarian, E stands for endometrial, I is iatrogenic, and N is not otherwise specified.
So can you give me an example of an endometrial cause?
So an endometrial cause could be like endometrial atrophy or a very thin endometrial lining.
Okay. So this patient had a hysteroscopic polypectomy. What instrument do you typically use when you're doing your operative hysteroscopies?
I use the MyoSure.
Okay. And what fluid do you use to distend the uterus? Did we do fluids already too?
It has been done. I don't remember if we did it together, but it's normal saline is the distension medium. You may have done it with another candidate. I don't know. It's all blending together now.
Okay, sorry about that. So what would be your fluid deficit cutoff? In other words, when you had a fluid deficit of what would you halt the procedure?
My fluid deficit for an uncomplicated patient, I would consider to be 2,000 cc's. And I know that's below the absolute max of 2,500, but 2,000 is typically where I say, okay, we're done.
Okay. And what about if the patient had cardiac issues?
If the patient had cardiac issues, the cutoff would be 750 cc's.
Okay. If you were using a monopolar resectoscope, what fluid would you use in that situation?
Well, this is not something I've actually ever done, but my understanding is you could use lysine or sorbitol.
Okay. And any idea what the fluid deficit would be at that point that you would stop?
I believe the fluid deficit for that kind of instrument would be somewhere around like 1,000.
Okay. What would be the concern of a large fluid deficit with scorbutara glycine? Do you know?
You'd be concerned about cerebral edema.
Okay. So if you had a patient, what about, would there be any electrolyte changes?
There would be a hyponatremia.
How would you treat a resultant hyponatremia, particularly if it were severe?
A severe prolonged hyponatremia would require the patient to be, well, first Lasix is a very good place to start, but then also hypertonic saline could be infused with the correction happening slowly so as to not cause cerebral pontine demyelinization.
I'm sorry, to not cause what?
Cerebral pontine cerebellar pontine demyelinization.
Okay. What is central pontine myolysis?
The thing that I was trying to say.
Oh, yes, what is it?
So it's basically herniation of the brainstem beyond the skull, which could lead to obvious deficit, paralysis, and death.
Okay, very good. So nice job, Ashley, and I'm sorry that it was a repeat for at least part of it for you. So you're absolutely right. The E is endometrial. Endometrial atrophy, chronic endometritis would be another one. And then you're right about your numbers. Certainly for the crystalloid and even for the glycine or sorbitol would be 1,000. And it is severe hyponatremia. In the short term, people would experience potentially seizures. They could have and other mental status changes. They can have cardiac issues, but usually it's the neurologic stuff that would show up sooner. And you're right, Lasix would be the treatment in an acute situation, but if it's been more than 24 hours for sure, you need to correct it slowly. And just as you said, regarding the central pontine myolysis. So the good news for you is—
remember what that is called, central pontine myolysis.
No, you're good. The good news for you is I'm sure we're not going to have too many volunteers, so I'll pick on you again for something maybe that we haven't done yet. So thank you.
Thank you.
Thanks. Okay, another volunteer, please. Come on, people. There you go. Hey, Tiffany, I'm trying to get it says there you go. How you doing?
Good. How are you?
Good. I'm sorry again about the foul up tonight with me being in the other webinar. But I'm so glad to see you guys. I can't tell you. Tiffany, refresh my memory. Are you a specialist?
Generalist.
Generalist. Okay. Let's do patient number 2. So she's a 30-year-old G2P1 at 40 and 3 days with PROM. She had a category 2 tracing with an intraamniotic infection. You induced her labor for the PROM. Intrauterine resuscitation, she received IV antibiotics for the infection, and you did a vacuum-assisted vaginal delivery. Apgar's rate 9, baby's weight was 3,000 grams. So what antibiotics do you use typically when you're treating a patient for chorio?
I use ampicillin and gentamicin.
Okay. And what about once the patient delivers? Do you stop the antibiotics or do you continue the antibiotics? How do you manage them?
I give an additional dose of both antibiotics postpartum.
Okay. And so this patient had a category 2 tracing. So what constitutes a category 2 tracing?
I guess long story short would be if it doesn't qualify as category 1 or category 3. Category 1, you've got moderate variability, and the only decel that you could have would be early decelerations. Category 3 would be absent variability with recurrent late or variable decelerations, as well as if there's a sinusoidal pattern, believe there's also concerns for bradycardia or tachycardia in there.
Okay. What intrauterine resuscitation do you attempt when a patient has a category 2 tracing? And how long would you tolerate it, so to speak?
You can do maternal repositioning, fluid bolus. If she's ruptured, you can place an intrauterine catheter and do an amniotic fluid or amnio infusion. In terms of how long I would wait for, I think it depends on whether or not she's got, in terms of the first step I would look at is whether she's got moderate variability in accels. And if she does, and there is also significant decelerations, or significant recurrent decelerations, then I would observe and try to resuscitate for an hour. If she does not have moderate variability in accels and she has significant variable or late decelerations occurring with more than 50% of the contractions, and I am not able to improve the fetal heart tracing in half an hour, then I would move towards cesarean delivery at that point.
Okay, what could you do to try to improve the variable decelerations?
Amnio infusion, in addition to like maternal repositioning, fluid bolus.
Okay. This patient, you applied a vacuum. What's the highest station you would apply the vacuum?
+2 station is the high station that you can apply a vacuum.
Where on the fetal scalp do you apply the vacuum?
So 3 centimeters anterior to the posterior fontanelle.
Okay. And what are neonatal complications of vacuum delivery?
So for baby, there's a risk of scalp laceration, cephalohematoma, bruising, subgaleal hematoma, retinal hemorrhage would be the big ones.
Okay. So can you tell me, do you do forceps at all in your practice?
I do not do forceps.
Okay. What are the pros and cons of vacuum versus forceps and vice versa?
With forceps, the big con is that there's an increased risk in maternal, like perineal lacerations and like progressing to more severe lacerations and progressing to 4th degrees. With forceps, you are able to use the forceps if the baby's head is not, occiput posterior. Like you have the ability to rotate the fetal head. With vacuum, there is less risk for maternal like tearing, but greater risk for the complications to baby that we mentioned in terms of like cephalohematoma, subgaleal bleeding. And I think the success rate is lower with a vacuum delivery. You also cannot do rotational maneuvers with a vacuum.
Okay, you mentioned 3rd and 4th degree with forceps. If you had a patient with a 4th degree laceration, do you give prophylactic antibiotics when you do your repair?
I do.
Can you tell me how you would repair a 4th degree?
So a 4th degree is basically a tear through and through from the vaginal mucosa to the anal mucosa. And so I would start with repairing the anal mucosa. After that, I would find the external anal sphincter and reapproximate that layer and then do the usual second-degree perineal laceration repair.
So how would you repair the rectal mucosa? Running, interrupted? What suture material would you use?
In terms of repairing the rectal mucosa, I would do a running suture, and I have used 2-O-Vicryl in repairing the rectal mucosa.
What about for the anal sphincter? What would you use there?
I would also use the same suture, but in terms of the manner in which I would repair the external anal sphincter, I would grab the two ends, the end on the left side and the end on the right side. And if you kind of like, I don't know, I guess I kind of imagine it like a cylinder that in a donut, I guess. And then if you like turned the ends towards yourself and looked at it as if it was a face of a clock, I would repair both sides, like reattaching the like I guess at 12, 3, 6, and 9 o'clock, and reattach those ends together. Does this kind of make sense?
Okay. So what about, let's say you had a patient with a 4th-degree laceration, and and you do your repair. What instructions would you give the patient? In other words, what post-op direction would you recommend?
So in terms of post-op counseling, I would discuss with her the importance of a good bowel regimen and avoiding constipation. So making sure that she's well hydrated, taking stool softeners such as Colace, other things that can help with that would be prune juice, increasing her fiber intake, and taking Metamucil. For perineal healing, I would recommend, discussing good hygiene, including use of a peri bottle, and, sitz baths can help improve healing of the perineum as well. I would discuss with her the high risk of the wound or like repair breakdown, and give her precautions if she's having discharge, out of proportion, pain, to follow up sooner rather than later.
Okay, so what would you do, I'm sorry to keep you in the hot seat so long, but what would you do if, let's say 2 weeks later she comes back to your office complaining of stool coming from her vagina, and you examine her and see there's a total breakdown? What would you do?
I would take her to the operating room and repair the breakdown.
Wouldn't you be concerned that she'd be at increased risk for a re-breakdown, if you will? If that's what you plan to do.
Yeah. So I believe the options in this scenario would be taking her back to the operating room right away and repairing it, and the alternative would be letting it kind of heal the way it is, and when the integrity of the tissue is better, then repairing it at that point. But I would take her back and immediately and repair it in the operating room.
Okay. All right. Very good. Let's talk about this one. So good job on the choreo. In terms of the neonatal complications, I think you covered certainly the big ones. Unlikely to have any kind of fracture of the skull or anything like that, but you could have intraventricular hemorrhage with a vacuum, and I think, I'm not sure if you said scalp bruising or not, but you got certainly the other major ones. In terms of vacuum versus forceps, so you're right. Forceps tend to be more successful. You can use them in asynclitic situations. You mentioned rotation. One thing we didn't mention was using them on preterm infants. So you can't use, as you know, vacuum less than 34 weeks, but you could use forceps below 34 weeks. And again, +2 station. I think that's it for the vacuum versus the forceps. You were right in terms of, less maternal trauma with vacuum, certainly increased with forceps in terms of tears and what have you. So your repair was fine. Don't forget to mention, of course, that you would want to repair the internal anal sphincter as well as the external. So
Okay.
it's both. And again, you can do a running on the rectal mucosa or it's the perirectal fascia, but you can do a running or you can do closely interrupted, but you want to keep your suture out of the actual rectum itself. So after your repair, you want to check it. You don't want the suture actually going through to the rectal mucosa.
Okay.
The reason you don't want that is because it could form granulation tissue. So you have to be a little bit careful, and check that. So the antibiotics is optional at this point. I suspect in the future it will become a recommendation. More and more people are doing it, especially with a 4th degree, to a lesser extent with a 3rd degree. So let's see. What was the other thing I was going to mention to you? Oh, so your bowel regimen, I think you described, was good. Now, if it breaks down though, and I think there's a pearl of excellence. It may be, 6 years ago at this point. Not sure how old it is. But what you would want to do in the situation of a complete breakdown is you would take the patient to the operating room. You'd start her on antibiotics, and you'd want to debride the tissue. The whole idea is you're trying to get down to healthy tissue, but something caused the breakdown to occur. It could have been trauma. She could have put something in her vagina, for example, or she could have had an exceedingly large bowel movement, maybe constipation, what have you. But something caused the breakdown, and chief up there in terms of causes would be infection. So you want to make sure you're approximating healthy tissue, because if you don't approximate healthy tissue, it's going to come apart again. And the more times you try to repair it, the more likely it is she's going to have permanent problems. So you would debride her, take her back in a day or two to the operating room, and you keep doing that every other day until when the tissue looks healthy. They do talk about waiting even up to a week, and then repairing it.
Okay.
So like a week of healthy tissue, and then you would go and repair it, because then you're sure that beyond what you've debrided is still, you've debrided down to healthy tissue. Let's put it that way.
Gotcha.
Obviously, you can't see microscopic seeding of bacteria, so you don't know that you're not going to take off a tremendous amount of tissue. You only have but so much to work with to begin with. So you want to take as little as you can, but till you get down to healthy tissue, or what appears to be healthy, but doesn't mean it's not seeded with bacteria because of the area that you're operating.
Okay.
In terms of the healing by secondary intention and then doing a revision 3 months later, that's what used to be done to these poor women. So this is actually an more advanced, sooner closure. So that's the point behind this one.
Okay.
Any questions?
Yes. So
I was waiting to hear no. Geez.
in terms of suture, I mean, I'm very used to using 2O Vicryl, but I guess like from your perspective, and you see more of these, like what suture would you recommend?
So the 2O Vicryl is certainly fine for the sphincters, but the 4O would typically be what's used on the rectal mucosa. Well, I'm saying mucosa, and that's really not precise on my part, on the perirectal or the rectal fascia.
Okay. And then in terms of like when you debride and repair, and I'm just kind of curious too, like in that interim time, like are there special things that you do for the patient? I mean, if it's, for example, if it's this breakdown of a fourth degree, like, are you just continuing with the bowel regimen while?
So the bowel regimen, yeah,
Okay.
the bowel regimen as well as the antibiotics. I mean, certainly, definitely like a sitz bath, especially after she has a bowel movement. You want to try to keep that area as best you can as clean as possible. And to be honest with you, if this question came up as a board question, it wouldn't be inappropriate for you to say, that you would bring in a colorectal surgeon or you would bring in a urogynecologist, to work with you. If they're not available, if they say they're all on sabbatical in Rome or something, so be it. But it wouldn't be wrong or like, hey, you should do this on your own kind of thing if you mentioned that.
Gotcha. Okay.
I mean, because most of us haven't seen that situation. We've seen, I've never seen one acutely break down. Let's put it that way. I've seen, having broken down in the past kind of thing, but not repairs. Not saying that I couldn't have one. I just haven't personally, thank goodness, experienced one. So,
Gotcha. Okay.
Pretty miserable for the patient, as you can imagine.
Yeah.
We good?
Yes.
By the way, guys, we will stop at around 9:25. I'm going to kick it back 5 minutes later because we started late. But to go over any questions, if anybody has any questions about cases that we did cover tonight. Thanks, Tiffany.
Mm-hmm. Thank you.
Okay, I need a volunteer, please. There you go, Ebony. Guys, you should all take a chance being in the hot seat. Tiffany can tell you how wonderful it was. Ebony, I'm trying to get you off mute. It says you're self-muted. There you go. How you doing?
Pretty good.
Ebony, refresh my memory. Are you a generalist or
Generalist.
are you? Okay. So let's see. This is one of my favorites. Have we done smoking yet?
No, we haven't.
Well, there you go. Don't you feel lucky? All right, so in a second, I'm going to actually show you your list.
I was going to say, is that my list? Oh, no. Okay.
It is now. Patient number 6 is a 42-year-old G1T1 with abnormal uterine bleeding. She failed medical management. She also has tobacco use disorder. History and physical pelvic ultrasound management options discussed. Endometrial biopsy was done. Ablation is to be scheduled. Tobacco cessation counseling. The endometrial lining is 10 millimeters, and the biopsy was negative. So tell me, Ebony, when you have a patient who's a smoker, how do you counsel them about smoking cessation?
I try to establish how long the patient's been smoking for, and whether or not they are interested in quitting. I give them information regarding the importance of smoking cessation and the risk of smoking on their health. And I give them resources to help them quit if they're interested. And I typically have them come back to either follow up with me or with a counselor to help them with their smoking cessation.
Okay. So when you tell them, obviously you tell them, I'm sure, the dangers of smoking, not that they haven't heard certainly some of them.
Right.
From a gynecologic standpoint, so we know, for example, smoking causes lung cancer, but that's not GYN specifically. How do you counsel them with respect to the risks from a gynecologic standpoint?
I explain to them that it also increases the risk of cervical cancer as well.
Okay. Anything else?
And ovarian cancer, I believe.
Do you know which one?
I'm not exactly sure at this moment.
Okay. Any other concerns from a gynecologic standpoint?
It can affect fertility. So for my patients that come to me that are interested in conceiving, I explain to them that tobacco use can decrease fertility. And then it also puts them at risk for blood clots if they're on other medications that also can contribute to that as well. And so for my ladies that want contraception and they're greater than 35 who are smoking, I explain to them that it limits their options for contraception at that time.
So, do you know how it affects fertility?
I believe it affects the motility of the fimbria, the fallopian tubes. It decreases motility, which is necessary for for conceiving.
Okay. In pregnancy, what are the adverse effects of smoking as it relates to pregnancy?
The biggest risk with smoking is concern for small gestational age fetus. And if the patient has asthma, concurrent asthma exacerbations.
Any other risk, let's say, to the neonate when he or she goes home?
I believe, and from where I am now, we have a lot of patients that are substance use disorder as well as tobacco use, and we find that those babies that are born to those moms also have issues with transitioning and with substance. I don't want to say withdrawal. The word is not coming to my mind right now, but they have issues with weaning off of tobacco as well as substances.
Okay. So if you have a patient, let's say this patient were in fact pregnant, and you're counseling her about the dangers of smoking, what smoking cessation medications or aids could you recommend for her if she were pregnant, or would you recommend?
Well, once I assess her willingness to quit, and if she's interested in medical therapy as well, I do offer, depending on other symptoms that might be present, if the patient has a history of depression or is expressing depressive-like symptoms, and I can offer her Wellbutrin. And I typically try to stay away from tobacco products like a nicotine patch or gum, just because if they're still smoking, then they're receiving, in addition, more tobacco.
Okay. What about Chantix? Could you use that in pregnancy?
I haven't prescribed it in pregnancy, and I'm not exactly sure there are studies available to the safety of Chantix in pregnancy, but I can look into that.
Okay. All right. Very good, Ebony. So I guess the example of this to you and to your colleagues on the call, not a rocket science type question on the one hand. On the other hand, it is something that they would expect you guys to be able to do. And it's kind of like when a well woman visit comes up, it's really frustrating if we can't score all the points on those, because it's like, this is stuff that we feel like we do, fairly regularly. We don't see the primary amenorrhea, thankfully, on a regular basis, but cigarette smokers, I'm sure you probably at least have a handful every week, if not more. Okay, so let's go over it. So smoking, I thought you did a nice job. So smoking from a GYN standpoint, you mentioned cervical cancer. You're certainly right. So actually any HPV-mediated disease, so cervical, vulvar, vaginal dysplasia, and of course cancer, they are at increased risk for, you mentioned ovarian cancer. You're absolutely correct. It's mucinous cystadenocarcinomas, in fact. They're also at increased risk for type 2 uterine cancer. So not your normal endometrial cancer. In fact, it's actually protective for that. But the type 2 uterine cancers are increased, in smokers. Bladder cancer, kind of in our neighborhood. Breast cancer is also increased. And then you mentioned infertility, and you're absolutely correct. It does slow the movement of the cilia. It's not the fimbria, but the cilia and the fallopian tube. So you're right concept, and certainly you get credit for what you said. So there's actually an increased risk in ectopic, or it is a risk factor for ectopics. The other way it actually works to reduce fertility is it decreases ovarian reserve. So these patients go through menopause on average about 3.5 years earlier than somebody who doesn't smoke. So between the combination, can make fertility more difficult. Also can put the patient at increased risk for osteoporosis because of the, again, earlier menopause. Trying to think if there's anything else. I think that covers from a GYN standpoint. From an OB standpoint, you mentioned small for gestational age, or which is absolutely correct. Certainly, growth restriction can be an issue with these folks. Placental abruption, increased risk of miscarriage, increased risk of FDIU are all increased. And the thing I was kind of looking for the neonate going home, is there an increased risk for SIDS? And also for having reactive airway disease, meaning the neonate, so pulmonary issues, asthma, and things of that nature. So I liked what you said about the Wellbutrin, and you were spot on with not. A lot of people, if I ask them about what they would use in pregnancy, they'd say, well, the patch and gum. But you're absolutely correct. The concern about the patch and the gum is that the patient's not going to cut down on her smoking. So now she's getting even more nicotine because she's not cutting on her smoking, yet she's using the gum or the patch. So Wellbutrin would be an acceptable choice. Chantix, the information is a little scanty, but it's still thought that the benefits outweigh the risks. So it is something that you could prescribe with caution, at least at this point. But you're right, the data is very limited. Any questions, Ebony?
Not right now.
Okay, very good. Thank you for volunteering.
Thank you.
Sure.
Oh, I can't hear you right now. Hold on.
All right, sorry. No, sorry about that. Maria,
Okay.
Ashley, give me a second. Maria, it says you're self-muted. Do you want to try to unmute yourself? There you go. Ashley, I'm sorry. We got Maria now.
Oh, no worries.
Thank you. Thanks, Maria. Sorry, I was giving you instructions, but I was giving them to myself. I'm having one of those nights, you guys. Something to look forward to when you guys turn into old geezers like me. Are you a generalist, Maria?
Yeah.
Okay. Let's see. Be just a second here. Chronic pelvic pain. Patient number 16 is a 32-year-old nulliparous patient with chronic pelvic pain who failed medical management. You did a diagnostic scope on her, and she had no pathology. First of all, what's your differential for chronic pelvic pain?
There is a wide differential for chronic pelvic pain. You can include things that would be anything from GI to GU to GYN. So when I'm thinking about it, I try to divide them into those issues. For specifically to GYN, you want to think both, infectious causes, structural causes, I guess iatrogenic causes, I haven't perfected my spiel yet, but that's kind of the start.
Okay. So this patient had chronic pelvic pain. When you have a patient with chronic pelvic pain, I know some of your workup is obviously based on the history that they give you, but in general, let's say the history is not necessarily specific for any one thing, but it's, let's say it's pain all month long, but worse at the time of first cycle. What would your workup typically consist of in that situation?
I think you mentioned doing the history and physical, obviously, to start off with. I would like to get a transvaginal ultrasound and assess, for any structural issues. And, doing the physical exam, paying, good attention to see if I'm eliciting any pain while I'm doing any specific exam. Trying to do, I guess, minimal interventions in the beginning to sort of tease out, what is or isn't possibly the cause. And I do like to start off with some form of medical management to see if there's any improvement, and typically have the patients return in about 2 months to assess and see where they're at.
So for this particular patient, what was your working diagnosis after doing her history and physical and whatever initial workup you did?
I was concerned that she had endometriosis.
Okay. So do you recall, or in general, what medications would you try for a patient you suspected had endometriosis?
I typically like to use things that don't have estrogen in it, so things that have, obviously that are progestin based. Before going to, I guess, hormonal medication, I do try, the NSAIDs, see if that works. They've typically tried it when they come to you and say, like the Motrin, the ibuprofen isn't working. But then I would encourage them to try to obtain, or at least allow us to place an levonorgestrel IUD, the Nexplanon if they won't take the IUD, Depo, and at the very least, even progestin-only birth control pills, contraception.
So, I mean, what's wrong with giving somebody combined birth control pills?
I believe the thought that the estrogen may cause that cyclical bleeding that is occurring due to the theorized, or I don't even know the word to say that, but the theory behind endometriosis being that there's endometrial implants in the pelvis and the abdomen or wherever it might find itself. And by giving the combined pill, that would cause like the cyclical pain. And the progestin would essentially shut that down and prevent the shedding causing the pain.
What about if you gave them continuous birth control pills?
In theory, that would probably be a good idea. I typically tried to use the progestin-only methods, having had more success with that.
Okay. Is treatment of endometriosis, is that one of the uses of birth control, combined birth control pills?
I'm sorry?
Is treatment for endometriosis one of the indications for, or one of the uses of combined birth control pills?
I believe it is.
So basically, whatever it is you used on this particular patient, it didn't work, and you proceeded to doing a diagnostic laparoscopy. And since you have no pathology listed there, I'm assuming the scope was negative. Is that correct?
That is correct.
So what did you do with this patient after the surgery then? I don't mean in the immediate post-op, but I mean, what did you do as far as your pain goes?
Well, I discussed with her the findings of the diagnostic laparoscopy, which she knew would be a chance that we wouldn't see any pathology. Based on her history, I said that even though we can't say this is endometriosis confirmed by laparoscopy, we could still try the methods that we would use to treat endometriosis and or pelvic pain. I believe in this specific patient, I did encourage her to first, or at least to next, try pelvic floor physical therapy.
Okay, so when you said, you would treat her potentially as if she had endometriosis still, I mean, you just told me she failed medical management, which I assume was some progestational agent, since you were thinking that she had endometriosis in the first place. So why would you think it would work now?
Well, that's a really good question. In this specific patient, she came to me almost asking for a diagnosis and requested a diagnostic laparoscopy. So when I was counseling her, I said we need to try the medical therapy to see if this improves your pain. So she knew going into the procedure, after we had tried for a couple of months of medication, that the laparoscopy may or may not confirm endometriosis. So I don't know if there was more or less a placebo effect in having the procedure, but at that point she was willing to try other modalities of medication.
Oh, so she refused medical management?
She tried the Nexplanon and would try nothing else.
Okay. I mean, did you consider getting a psychiatric evaluation on this patient?
No, I did not.
If the pelvic floor physical therapy doesn't work, what would you do next? Or what other options would be available to her?
Well, I was hoping the pelvic floor physical therapy would go in conjunction with any sort of medical therapy, and I would again reevaluate her desire for an IUD.
Would you ever use like a GnRH agonist to see if that improved her pain, kind of as a mini test?
Yeah, that's a
or
good idea. The Elagalox, I could certainly would want to save that, since the amount of time that you can use it is for such a limited use. But I guess that, having not done that yet in my practice, that would be a good idea to see if that was treating her pelvic pain.
Okay. All right. Very good. Thanks, Maria. So, this is kind of a tough, not this specific case per se, but this topic can be tough for folks. When you have chronic pelvic pain, they fail medical management, you do a scope and you don't find anything. And it's like, now what? And sometimes candidates will say, well, now I'm going to send her to the urologist for a cystoscopy to see if she's got, interstitial cystitis. Or I'm going to send her to GI for a colonoscopy, possibly because, maybe she's got irritable bowel syndrome or who knows what. But not that you diagnose that on colonoscopy per se. But so it's really, and then, the examiner responds, well, if that's the case, why didn't you send her before you, stuck a scope in her belly button? So it's a little bit of a slippery slope to explain one like this. Hey, I tried medical management, it didn't work. So your pelvic floor physical therapy is certainly a reasonable post-op, if you will, approach. A pain center would be less optimal, but certainly another approach. And the other thing you could always say is you could try, encourage the patient to have a trial of an SSRI therapy. About 40 to 50% of patients that try an SSRI have some improvement in their pelvic pain. So there are three kind of things you can do after the fact, if you will, if you end up with one of these negative laparoscopies. But when people say, oh, I'm going to put her back on, birth control pills or whatever it was that, it's like, well, geez, it didn't work pre-op. What makes you think it's going to work post-op, kind of thing? Does that make sense?
Yeah, absolutely. I mean, I can't believe the questions you got out of those 4 lines. It's crazy.
Well, and when you're in the hot seat, you're not sure. It's not that you're not sure what you're saying, but you're not sure how it's being received. It really makes it, that much more difficult. I mean, even the patient above that's 25 with chronic pelvic pain, she doesn't have failed medical management, but she had the hemosiderin deposition. So, she probably had some endometriosis, but let's say that had come back negative. At least in her case, she had a lysis of adhesion. So you could say, well, hey, she was feeling somewhat better after, most likely was the adhesions, but this lady's got nothing.
I have a quick question, if you don't mind, about the lysis of adhesions. We were always taught in residency that the theory behind the lysis of adhesions is that you're restoring normal anatomy, therefore, I guess, potentially helping treat pelvic pain. But I can't recall where, but I thought that was not a reason to do lysis of adhesions.
So that's a great question. So if somebody has filmy adhesions, it's probably not causing them significant discomfort. You know, lysis of adhesions is a little bit of a tricky thing. If you have somebody that's got, you know, some pretty decent adhesions, especially if it's distorting the anatomy, then you may buy them some significant pain relief. You know what I mean? Like if that ovary is plastered to the sidewall and can't move kind of thing, you can imagine she could have dyspareunia, for example. So it really, it depends. But, you know, if somebody has some of these like super filmy adhesions, probably not doing a whole heck of a lot.
Okay. So I won't sound silly if okay.
Yeah, I mean, you know, and quite honestly, you and I both know that sometimes there's the therapeutic diagnostic laparoscopy where the patient, you know, is real, her, you know, best friend's sister twice removed on her grandmother's side was diagnosed with, you know, ovarian cancer. And so she's got a closet worry that she's got ovarian cancer, and you show her the pictures from the laparoscopy and suddenly she feels much better.
Yeah.
So, and again, I'm not trying to minimize it or whatever. I mean, we all worry about certain health things, you know.
Right.
So, you know, sometimes those kinds of things, the pain gets better. Yeah. Very good. Thank you for volunteering. Sorry, I had trouble getting you off mute. Actually, I had no trouble getting you off mute. I had trouble telling you I had unmuted you.
No problem. Thank you.
Thanks. Okay, we are at 9:30, so let me just pause for a second. Does anybody have any questions about anything we talked about tonight, or in general questions, board-related questions? I know you guys got that email from ABOG regarding the change in the test structure a little bit. Any questions? I don't know that I'll be able to answer them, but I'll give them my best. Okay, let me just tell you what I do know about the change. I can tell you that in May, ABOG, I think it's ABOG, or maybe it's the DO organization, but the DO candidates who are choosing not to go through the certification of ABOG, I think they're being certified by their DO. I don't know, I'm not 100% sure, but I do know that there is a separate exam where they don't actually necessarily have to prepare a case list and all that kind of stuff. The DO exam this May was given virtually. So I do know that the candidates had to download some special software on their computer. I'm not sure why or whatever. I think the suggestion was it was somehow going to be quote unquote more secure. So I know ABOG is going to have you guys configure your computers, and they'll provide more information as we get closer. So from what I understand, it's going to be just like the boards were, but instead of sitting across from them, you'll be sitting, I think at your home or office computer, and again with this special software, and you'll still have the two examiners at a time. That is my understanding, but again, I have not heard this from ABOG. I'm only putting together what I did hear from ABOG with what was happening with the DO folks. So if any of you guys have any friends that are DOs that took this in May, they'd be able to tell you kind of exactly what the software was and how it worked. And I suspect that's exactly what ABOG will do as well. Okay. I'm glad they're not doing written for you guys' sake. I'm not sure that the written is necessarily any favor for the folks that took it last year. Any last minute questions before we wrap up? Okay, Tiffany, hang on one second. Okay, Tiffany, I'm trying to take you off mute. It says there we go. Oh, try one more, there you go.
If possible, I was just wondering if I could run one of my OB cases by you, because as I was looking at it, I realized that this lady was delivered at 35 and 2, and now I'm thinking, how am I going to defend this?
Okay, so Tiffany, I'm happy to talk to you about it, and I'll take you back on just a second. Let me just, because I'm going to get Ebony's question. That way, if anybody wants to drop off, they can, or if they want to stay and listen to your case, they can do that as well. Hang on one second.
Okay.
Ebony, I'm trying to take you off mute. It says you're self-muted. There you go.
Hey, just quick question. I know our case list and everything is due tomorrow. No judgment. I'm still working on mine. Does anyone know if there's a specific time that it needs to be in by?
I'm not sure. And if anybody else does, please raise your hand. I suspect it's by close of business, but that is a complete guess on my part. And remember, their central time in Dallas. And you know there is the late submission but I think you have to pay a fee or something.
Yeah.
So that is always if you really need extra time.
Yeah, that was sent, I think on Thursday, and they said August 16th at 11:59 CDT.
Oh,
Okay, thank you so
cool.
much.
Thank you. You just bought yourself an extra 6+ hours there, Ebony.
I'm just kidding.
Great.
All right.
Hang on one more second, Tiffany. I got one more question here. Maria?
Not to be a freak, but 11:59, I'm assuming like PM, correct? Like close to midnight?
Yes.
Okay.
Yes.
Thank God.
Central time.
Okay.
Okay. Any other questions before? Let's see. We got Ashley's got a. Yes, it's midnight, but I don't know what time. Thanks, Ashley. Okay, last call for questions. You guys can stay on and listen to this case, or you can drop off. It's up to you. Tiffany, let me pull up your list. Do you know what patient it was?
Yeah, it's the OB case list, patient number 11.
All right. Give me 1 second here.
35 and 2.
Okay, so just for those, since we still have some folks that are listening in, so we'll make it worth their time as well. 30-year-old G1P0 at 35 and 2, oligohydramnios, variable D cells on NST, gestational hypertension. She had fetal intolerance to labor. Ooh, hate that diagnosis. Category 2 tracing, preeclampsia. So you gave her steroids, antenatal surveillance, induction of labor, failed intrauterine resuscitation, and primary low transverse C-section. 8-9 APGARs, 2490 was the weight. So what's your worry here?
Yeah, so
fetal intolerance to labor.
So I took that out. I changed it to category 2 tracing, and so this patient had like I can't remember if it was low or elevated, but abnormal AFP. So she was getting antenatal surveillance, and then she had oligo, and she was admitted to the hospital for observation. Ended up having variable D cells, but technically oligo and variable decelerations in itself, I don't like. In this case, I'm thinking, and it was my partner who had decided to induce her, like, shouldn't a BPP have been done if there was concern and need for delivery? And even if a BPP was done, worst case scenario, -2 for oligo, -2 for a non-reactive tracing, which would have still been like 6 out of 10. So in that case, being less than 37 weeks, technically she could have had a repeat BPP in 24 hours. And oligo in itself would have been like you would deliver at 36 weeks to 37 and 6. So I'm just trying to.
How bad was the oligo?
Not that bad. Technically it was oligo, but if you're going by textbook criteria, yeah, it wasn't like 0 or like by any means. So it had been low, and I feel like this was kind of a soft call, and I don't know if a way to defend myself would be to say, like, my partner decided to induce her and she was AROM'd by the time I came on, so I continued the induction of labor. The tracing got worse, failed intrauterine resuscitation, and then hence the primary C-section. And then if I had managed her, I guess I would have done a BPP and kind of managed her the way that I had previously mentioned. However, if it was a really bad tracing with like minimal variability and like recurrent lates or variables, then I would have tried intrauterine resuscitation and moved forward with the cesarean delivery if that hadn't worked.
Yeah. So, well, let me ask you a question. So the gestational hypertension, was that getting any worse? How was that behaving?
She declared herself with preeclampsia postpartum, but it wasn't like she had severe range blood pressures requiring like resistant to treatment and needing immediate delivery type of thing.
No, I get it, but I guess here's how I would look at this case. I mean, I see that she's got oligohydramnios. She is 35 and change. You did give her steroids. Now, did you deliver at 35 and 2, or did she come in at 35 and 2 and have a 6-day length of stay?
No, she was delivered at 35 and 2, and she was admitted
Okay.
like the day before.
34 and okay.
Yeah.
Or 35. Yeah, I mean, look, when I look at this, she's got gestational hypertension. She's got oligo. I'm thinking, well, the oligo may be because of the gestational hypertension. She's 35 plus weeks. She did get steroids. Obviously, there was not a tremendous amount of reserve for the baby because, I mean, the variables, okay, that's from the oligo, but the category 2 tracing, particularly if it's persisting and failed intrauterine resuscitation, I mean, this doesn't stand out to me like a sore thumb. I mean, the BPP of 6, if it were 6 out of 10, I probably would have repeated it in about 12 hours personally. But, I mean, there's something going on with this patient. And, you can make a case for, winning the battle but losing the war. So, sometimes it's, you've got to use your judgment and put everything together, and you can't just apply it necessarily a specific recommendation that's kind of in isolation. So I think, it's certainly reasonable if you're really uncomfortable about it, and they ask you about this case, how come you induced her at 35 and 2? My partner was actually following this patient. I assumed, duty, when I came on call at 5 o'clock, she, was ruptured and whatever. And, if I'd been managing her, I would have, repeated her biophysical profile the next day. But this is what this is what was being done. I mean, that happens all the time, to be honest with you, because, a lot of us take call for, especially if you're in a faculty type practice, at a teaching facility, and you come on call at 5 o'clock. I mean, it just happens. So I wouldn't be terribly worried about this case.
Okay. All right. I think my concern is just, do you see there being any like kind of nitpicking based on like, like nitty gritty, like BPP, this scenario versus that scenario, how bad the tracing was, and like trying, like in the line of questioning with oral boards where it's like, it's the slippery slope and they ask you what you would do in each scenario type of thing. And like, when would you section? I think that's my concern.
Yeah, no, they certainly could. I mean, the oligo and the gestational hypertension obviously go together, and the variables go with the oligo. So all that kind of makes good sense, but they don't know how bad or not bad her gestational hypertension was or her oligo.
Okay.
I mean, when I'm seeing oligo at 35 weeks, especially in the face of hypertension, I'm thinking that, hey, this lady ain't gonna make it to 39 weeks. And quite honestly, she may, not going to make it to 37 weeks. It really just depends. And as it turns out, again, I'm exaggerating here a little bit, Tiffany, but you kind of did a contraction stress test on her of sorts, or an oxytocin, an OCT on her, and she had a category 2 tracing when you did. So, I mean, we could look at it the other way and it's like one of these, oh, thank goodness, we kind of caught her in time. We didn't end up with an FDIU.
Okay. All right. Cool.
Again, when you know all the details, sometimes we get that much more paranoid. But if, as somebody who doesn't know all the details here, but just sees the oligo and the hypertension, I mean, it kind of all goes together with me. And I'm thinking the oligo is worse probably than maybe it was.
Okay.
Because I'm seeing the variables, I'm seeing the category 2 tracing. So I'm thinking, good thing they moved when they did.
Gotcha. Okay. All right. And then one last kind of unrelated question. I think in like the caseless defense talks, Dr. Shamroth talked about how like you can put the most concerning or like, yeah, the most complicated case first. But I just wanted to confirm, I don't think that's really an option, right? Because they're broken down by categories. So it's not like you can really put the most complicated case first if it doesn't follow that category order.
Yeah, I have to confess, I don't know with the ABOG software if they let you move categories. Do you know what I mean?
Yeah.
So in other words, could you put your breaches as your first category? Just making this up. I don't know that they do or don't. Do you know?
I don't think that's an option. It's kind of it kind of just populates based on the categories that you enter the patients
So
in,
it's preset.
and then
You think
there's
the
no
category order?
yeah.
Okay. Again,
All right.
What you would want to do is then make sure it's one of the first two patients, if you can, in a particular category.
Okay.
But again, I don't know. I that was good in the day, but I don't know that that's absolutely critical anymore anyway.
Fair enough. Okay. Thank you.
Very good. My pleasure. All right, guys. I think we will wrap up. I appreciate, so let's see. Yes, it's been Central Standard Time. Yep. Thanks, Ashley. All right, guys. Well, hey, I appreciate you hanging in there. And again, I apologize about the late start and sorry also for keeping you late. I will look forward to speaking with you guys coming up I'll look forward to speaking with you guys on the 30th. In the meantime, obviously, you'll have other folks carrying through. I hope you all have a good week and good night.